the University of San Francisco, and we know each other since very lot of years, and so we work together in the future as well, I hope so. And I'm very happy that you join us again, and we look forward to your talk.
Vielen Dank, Hartmut.
Ja.
Mein Deutsch ist nicht so gut, aber es ist so schön, dass ich kann zurückkommen. Ja? Close? Dr. Goebel said that this is a very complex topic. It's nicht einfach, right? Nicht einfach. Aber so many people have it. How many people here have had a patient mit vestibular migraine? I think most people. But do we, kann wir das verstehen? Nicht. Not really. Not me. But we're trying. And let's see if we can understand it a little better, but I don't have all the answers. So please ask, and let's discuss today. I hope we have time to discuss a little bit. Okay. So, what are we talking about? What is vestibular migraine? It's really a term to talk about episodic vertigo in people with migraine. Episodic vertigo in people with migraine. But we have lots of problems. Is it truly a diagnosis? Is it a distinct diagnosis? Or is it a form of migraine? Is it just a sensory manifestation of a phase of migraine? Sie wissen, prodrome, aura, migraine, postdrome. Is vertigo just a phase? Is it an aura? Is vertigo an aura? Sometimes I think yes, sometimes no, sometimes I think no, not an aura. And what are the mechanisms of this thing? What causes vertigo and migraine? And very important, how do we help our patients feel better? This is very, who among you has had vertigo? Who feels vertigo? I feel it, I have felt it. It's not nice. This is nicht schön. It's terrible. And it usually has nausea with it, and malaise, so it's important to treat it. All right, first of all, what is dizzy? Auf Deutsch, what is dizzy? What's the word? Dizzy? Schwindel? Okay, so what does that mean? It could mean vertigo, right, which we learn in school. Vertigo is from the inner ear, vestibular, the labyrinth, right? We think vertigo probably from the labyrinth. But what about disequilibrium? Another word is ataxia, right? Ataxia, disequilibrium. We learn that it is from the cerebellum. And then finally, lightheadedness. Do you have the word presyncope? We talk about presyncope, yeah. Presyncope, blood pressure, heart, you know. So we think that there are these three categories, but there's a problem. Vertigo, yeah, sure, it can come from the semicircular canals, but it can also come from other places in the vestibular system. Disequilibrium, yeah, it can come from the cerebellum, but it can also be due to vestibular dysfunction. That's a new idea, but I think it's true. Also, lightheadedness, presyncope, can be a vestibular symptom. Another new idea, but I think it's true. So, there is a Venn diagram. I love Venn diagrams because when I don't understand something, I make a Venn diagram and maybe I understand a little bit better. Vertigo, disequilibrium, presyncope, there's overlap. The vestibular system has a lot of components. It starts with the semicircular canals, but then it involves the acoustic nerve, vestibular nerve, acoustic nerve, brainstem centers, brainstem nuclei, and very complex interconnections in these nuclei, which you see here. Is this arrow coming? I don't see an arrow, that's okay. And then cortex, temporal lobe cortex. So lots of places in the system where there can be problems, like cortex, cerebellum, nuclei, spinal cord, acoustic nerve, vestibular nerve, semicircular canals. Any of these places can have problems and lead to vertigo. You know this. Migraine, I think, mostly involves when there is vertigo with migraine. I think it comes from either the cortex, cerebellum, or brainstem, I think. There are important connections between migraine and vertigo. First, migraine is more common in patients with vertigo. Vertigo is more common in patients with migraine. Migraine people, I'm a migraine person, I don't know about anybody here who has migraine, get motion sickness, get vertigo with movement in a car, boat, plane, and motion sickness usually has some vertigo. Migraine is associated with 2 times the risk of benign paroxysmal positional vertigo. Meniere's disease. Have you seen cases of Meniere's disease? Very, very dramatic, severe vertigo. Half of the patients with Meniere's disease have migraine. That's a lot. Meniere's episodes, when a person has Meniere's disease and they have this terrible, strong episode of vertigo, they often have a migraine right after, just after. So why? Why is there a big association? Is vertigo a manifestation of migraine? Does migraine cause vertigo? Is it part of migraine? Is vertigo an aura? Is there a subtype of migraine where vertigo is very important? Is vertigo maybe a migraine trigger? Does vertigo from another cause lead to migraine? Possibly. One other possibility. Migraine, you know, is a disease of hypersensitivity. You know what I mean? Hypersensitive to noise, hypersensitive to light, hypersensitive to touch. Maybe people with migraine, like me, like some of you, notice vertigo. Other people might not notice. So perceptual. This is what the migraine mit aura looks like. Typical brainstem, hemiplegic, and retinal. What is migraine with brainstem aura? Well, migraine with brainstem aura includes vertigo, but it must have SVI symptoms, so vertigo plus something else. So that doesn't work for people with just vertigo with migraine. So the diagnosis doesn't work. So maybe it's a 5th kind of aura. You could say migraine with aura. Number 5 is vestibular migraine. Maybe, possibly. In other words, vertigo with migraine is just a different aura. Possibly. However, look at how vertigo happens in migraine. It doesn't just, es ist nur mit aura. Es ist the whole time, the ganze time, site of migraine. Doesn't make sense for aura. Let's see where I was here. Yeah. So maybe it's just a different type of migraine. You have migraine with aura, migraine ohne aura, chronic migraine, vestibular migraine, maybe. Here is the definition in the International Classification of Headache Disorders and the Bharani Society. Gleich, 5 episodes, history of migraine, and migraine features with Haupt episodes. So 50% of vestibular episodes have either headache, photophobia, visual aura, something like that. So episodes of vertigo, 50% have migraine features. So that's the definition. And I think it's pretty good. You use this one, use this definition generally I think it's pretty good. It's not in the complete ICHD3, it's in the appendix. So not yet, noch nicht in the full classification. Then we have probable vestibular migraine. I'm smiling because this is difficult. Probable vestibular migraine is too easy, too broad. because you can have episodes of vertigo with either history of migraine or some migraine features. I don't think it's tight enough. I don't think it's a good enough definition. And I think in research, we should probably, wir sollen nicht use this one. All right, I said just that. And what about chronic vestibular versus episodic vestibular migraine? Well, did you see patients, have you seen patients with not episodes of vertigo, but vertigo all the time? I've seen these patients. At UCSF, we see probably one patient each week. I see a new patient who says to me, I'm dizzy all the time. Each day, every day. So should we call it chronic vestibular migraine? I don't know, but possibly. It's just an idea. How do patients look who have vestibular migraine? What do they look like? What do they say? So it's episodes of vertigo, lasting seconds, minutes, hours, days. It can occur between migraine headache attacks. It can occur before, during, after, you saw on my chart. It can be spontaneous, or an episode can be caused by head movement, weather change, motion, riding in a car, mild head trauma, very subtle head trauma. So it can be spontaneous or induced. It's a little more common in women, like migraine. Generally, usually, vestibular migraine begins many years after migraine begins. I don't know why. Have you noticed this too? Have you noticed that tends to happen? Migraine first for a long time, then vestibular migraine happens, usually later. Unsteadiness, balance problems, presyncope, these are very common. Sometimes patients do have hearing loss. Usually not. And sometimes patients with vestibular migraine do very, very well with migraine medications. Not always. Sometimes migraine medications do not help. Very puzzling. This review looked at the prevalence of vestibular migraine, and it's high, but there are many problems. I don't have time to go through it, but many problems with determining the prevalence and incidence of vestibular migraine. But here are some numbers. Do you know this place? The Deutsche Dizziness Center in München. Yeah, they've done some very, very good work. But sometimes they use a different definition than we do. It's not the same. But they came up with vestibular migraine as being their fourth most common cause, very common cause of vertigo. They have, functional dizziness, psychological dizziness was their number one. I don't know if I believe that. I'm not sure. BPPV, number two, central disease, number three, number five was Meniere's. They're doing a lot of good research, and I think we will learn more about it from this center. They do all sorts of provocative testing, and they're very good at understanding this. I think the one that I've read most from is Strupp, right? I never met him, but I like his work. I think it's worth looking at some of his data, and I think the executive director is Brandt. All right, so let's talk about 3 cases. I brought 3 real people, cases, but I changed the pictures, so it's not the same picture. You understand? Yeah? No, okay. Not the real picture, but these are real cases. So for case number 1, migraines with sometimes vertigo, sometimes. She's a 35-year-old nurse. She has unilateral severe headaches since her teens. She has nausea, phonophobia, and she sometimes gets blurry vision. And sometimes the headache is preceded, so before the headache, she sometimes gets vertigo. Sometimes with the headache, she gets vertigo. Okay, case 1, sometimes vertigo. Oops. Case 2 is a teacher who has had migraines since childhood. They got worse around puberty. She has very bad headaches around her menses. And they got better. Headaches got much better during her pregnancies. And now she's had these 2 children and she's doing very well. Not very many headaches. But, and she never had auras. Never had auras. But over the last 3 years, she has had several episodes of vertigo. And it's so bad that she feels like she's being pulled to the ground. This is something like what Meniere's disease patients, they feel like they're being pulled down. Very, very unpleasant. Case 3. In other words, another real case, different picture. I work in the Silicon Valley. Is it Silicon Valley? Computers, AI, and lots of people, lots of very smart people work there. He's one of them. It's a different picture, but he kind of looks a little bit like that. Anyway, he said he's a 52-year-old software engineer, very well-known person. And he has had spells of up to 10 days long of unsteadiness, lightheadedness, photophobia, malaise, a little bit of vertigo, as I recall. Not very much vertigo, but unsteady and feeling just bad, malaise. Normal audiogram, and he was sent to me with the diagnosis of vestibular migraine. So 3 cases. We'll come back to that later. What are the causes of vertigo? I won't go through this in detail. You know I'm sure most of you know the causes of vertigo. This is a short list. There are many causes of vertigo. Remember the picture I showed you of the semicircular canals and the brainstem, temporal lobe, many, many causes. These are the most common.
Can I just ask, when you say vertigo, do you differentiate it from dizziness, or
Yes.
is it separate? Like you mean
Yes.
not dizziness, but like a
Yes. Tell everybody what you just said.
in German Schwindel is like it's sort of the
broad
heading, but
category.
then you divide it into Drehschwindel. It's like a turning sort of. It's the turning sensation.
That is like
you're in a carousel and the world is spinning around you. Okay, so you mean?
I mean the
like
world
vertigo.
feels like it's moving, or I feel like I'm moving.
Right.
Either. So we say vertigo is a sensation of movement, even when there's no movement.
In the German language, it's very difficult when the patients say, I'm near schwindelig, which means I am feeling, and it can mean vertigo, it can mean dizziness, it can mean sort of
Presyncope?
Presyncope, yes, exactly. Or it can also mean like maybe the earth is swaying,
yes.
like we say sometimes Schwankschwindel in Germany, so
Yep.
it's a swaying sensation, but yeah.
So this is only for the movement,
Right.
the cause of movement. However, remember my Venn diagram, my 3 circles, right? There is overlap. So, for example, someone with, let's pick one, benign positional vertigo. Benign positional vertigo, you move your head and you feel this spinning, this movement. But you might also feel unsteady.
Yeah.
You might also feel lightheaded. So it's difficult. Es ist nicht einfach. All right, but what are the most common diseases that look like vestibular migraine? So here's my list. Mal de débâclement, and I'll tell you more about this in a minute. Benign positional vertigo of childhood, benign paroxysmal positional vertigo in adults, persistent postural perceptual dizziness. Do you have this one? PPPD? 3PD? Something like that? It's difficult diagnosis. Meniere's disease, migraine with brainstem aura, post-concussive syndrome, and some problem in the vestibular system, whether it's semicircular canals or maybe acoustic neuroma, schwannoma. So these are the options. This is an interesting one. Do you know this one? Mal de débâclement. When you come off the boat, you feel not quite right for about, I don't know, 2 Stunden, ein Tag, but usually just a short time. These people feel it forever. They get off the boat and now they have this forever. And very strange, I won't go through all the details, but they feel like they're moving and You know what helps them? Getting into a moving car or going back on the boat. They feel better. It's very strange. They also have some cognitive problems, and they also have, many of these people have migraine. It's really interesting. Treatment for migraine doesn't help them. Migraine treatment doesn't help. Very difficult to treat these people.
May I ask a question?
Yeah.
Here we differentiate between central vertigo and peripheral vertigo. And I think this is an example of central vertigo.
I think so.
Where do you think is vertigo, vestibular migraine generated? In the brain or outside the brain? Is it peripheral syndrome or is it the central syndrome?
I think it's central.
The central.
I think it's cortical or brainstem.
Yeah.
In fact, if I had to pick one, I'd pick brainstem. I think that we humans have many, many connections between pain centers in the brainstem, nausea centers in the brainstem, and balance centers in the brainstem. I don't know why. Why do we have these big connections? I don't know. And I think that people with migraine very often have trouble with balance, vertigo, nausea.
Yeah.
I think that's why.
And if we have now a patient with peripheral vertigo, for example, lift experience or rotating experience,
Yeah.
can this be vestibular migraine or is this a different disease?
Oh, you mean when it's triggered? When it's triggered by head movement?
Yeah, for
Yeah,
example.
it's such a good question. I'm coming to that.
Yes.
Wait, yeah, it's a good question. Benign paroxysmal vertigo of childhood. We think this leads to migraine in adulthood. This is the one that's triggered by movement, very different than vestibular migraine. It's attacks of vertigo when you move your head, right? Usually with nausea, and we think it's because of canalids in the little canals. And the treatment is to push the little, what are they, Steinen? Little, yeah? Push them to the right place. So that's the Epley maneuver, to push the little rocks to the right place. Meniere's disease, you know this is quite bad. It's not common, but again, people with migraine are much more likely to have Meniere's disease. People with Meniere's disease are much more likely to have migraine. The only thing that helps us with Meniere's disease is usually they get a low frequency hearing loss. It helps to diagnose. This is a difficult one, as I said before, PPPD. We don't understand it. We don't really know the cause, but it is vertigo episodes, sometimes provoked, sometimes triggered, and sometimes these people fit the category of vestibular migraine. And many people with PPPD have migraine. Some people with migraine have PPPD. It's difficult. I think you here see many patients with head injuries, right? Many people with post-traumatic problems. One of the most common post-traumatic symptoms is vertigo. Headaches, for sure. Cognitive decline, somnolence, fatigue, but vertigo, very common. So, another Venn diagram. It's not the best Venn diagram. I think we need 3 dimensions, right? So I could make it, you know, if we had some balls, but really, there's much overlap. And this is why we are so confused and puzzled. But we have to become comfortable, I think. To learn more about this, we have to think to ourselves, we don't have the right words, we don't have the right concepts to understand this perfectly, but we can understand it a little bit with things like this Venn diagram. I made for you, and Dr. Goebel has this whole lecture, so he can share it with you, later, the slides. Anyway, I made a chart here. Notice, they have some different features, these things I just told you about. Interestingly, many of these things can be triggered by position. So even central vertigo can be triggered by head movement. I used to think that's not possible. I used to think if you can trigger vertigo by moving the head, must be peripheral vertigo, must be. I don't think that anymore. I think that turning your head and triggering can trigger central vertigo in the same way that, I don't know, a pressure change outside can trigger central migraine. Something about triggers, even though they are peripheral, can affect central conditions. Another interesting thing, look at vestibular testing. You know, like nystagmogram, you have nystagmography, probably. It's usually negative. All of these tests of hearing, balance, negative. What are the mechanisms behind this migraine vertigo association, this migraine vertigo problem? What is the mechanism? Could cortical spreading depression, which is the physiological abnormality that causes migraine, could that cause vertigo? Could blood flow, ischemia, could that cause vertigo and migraine? Or maybe migraine is a disease that activates both pain and vertigo pathways. Or maybe, like I said before, remember what I said, where people with migraine are very sensitive. Maybe we just notice, maybe we just see the vertigo quicker, easier than other people. So here's how cortical spreading depression might cause vertigo and migraine. You know, what if the CSD affected the parietal operculum, or you know, I guess insula, temporal lobe structures? What if the CSD caused something there and that could cause vertigo? So maybe you would say that's an aura, maybe. So it's possible. Could there be blood flow problem? Could there be ischemia? Yeah, sure. I think, but we don't see some. Having migraine makes it for a higher risk of stroke, but not that much higher. And you know, it would not. I don't think blood flow explains vertigo and migraine, but you know, maybe. And most of the lesions we see, most of the white matter lesions we see, are in the cerebellum. So cerebellum, vertigo, presumably, maybe. Maybe migraine is a condition that activates brainstem pain, Schmerz connections, and vertigo connections at the same time. Maybe. Or maybe, I don't know how to explain this, I can't say it in Auf Deutsch, but do you know when two nerve innervations convergence? Yeah. So if pain is converging with balance data, balance information, maybe higher centers wrongly interpret that, and it feels like vertigo, so convergence. All right, so practical matters. When we see patients with vertigo, what do we do? You know, we know it's going to, when I see a patient with vertigo, I know it's going to take a little more time, right? A little more time to understand, is this lightheadedness? Is this, there's different kinds of things he said. Those three things, yeah. Which one? So we like to make sure we're not having a heart condition, blood pressure, inner ear problem, so we try to understand it. Is there hearing loss, vision? You know, I won't go through all of this, but we ask lots of questions, and we want to know, is this new, is this old? Another way to think about this, when we meet our patients with vertigo, we can think about three syndromes. Is it episodic? Does the vertigo come for just a time and then stops? Is it provoked, unprovoked? Does it keep coming back, or is it all the time? Is it persistent? And so that helps us know what we're dealing with. You know this guy, Robert Barani, did groundbreaking work on vertigo. He won the Nobel Prize for Medicine in 2000. That's not right. 1914. I have to fix that. 1914, yeah. For his work in vertigo. And he invented the Barani maneuver to diagnose. Let me see if I have this here. Yeah, so with the Barani maneuver, there's supposed to be a peripheral pattern and a central pattern. We all learned this in medical school. It helps, but it's not perfect. And I won't go through this, but there is a way with the Barani maneuver, with this test that he invented, to distinguish between peripheral and central vertigo. And it helps. I don't think it's perfect. This is another test. It's called the head impulse test. Supposedly, the correction with the saccade, when you turn the head, if the eyes come back quickly, that's positive. And sometimes vestibular migraine has a positive test, sometimes vestibular migraine has a negative test. Difficult. These are the two people who invented the head impulse test. This is something, did you hear about this? It's called HINTS. It's the head impulse nystagmus and test of skew, another test that people use for diagnosing vertigo. I think this is a good one because it combines three different areas of information. I don't use this right now, but I think I'm going to start using this. I think it helps. Helps to distinguish between central, peripheral, vestibular migraine, benign positional vertigo. I think it helps. These are some tests that we can do in vertigo. You know, we can look for hearing loss, MRI to look for a mass, perhaps near the acoustic nerve, brainstem evoked responses, nystagmogram, nystagmography, video nystagmography. We have a lot of tests, but like I said earlier, they're usually negative, usually normal. This we see in Meniere's disease. You see where the arrow is. That's a person with, which year is this? Oh yeah, this is early and late. So 1 year before, and then now this person has Meniere's disease, has a low frequency hearing loss in 1 year, Meniere's disease. Brainstem auditory evoked potentials sometimes show us something wrong in the acoustic nerve, you know, but usually not. All right, so now what do we do with our patients who have vestibular migraine? We think they have it, we make the diagnosis. Even if we don't make the diagnosis, we like to help them feel better. So acute pharmacological treatment. This is for people who are usually feeling good, but they have an episode of vertigo. So zolmitriptan, triptans can help. This study by Marcus in 2006 had good results with rizatriptan. These are some other meds that have been used. I think they're all worth trying. We should have these as options. Meclizine, benzodiazepines, very useful, but we know about problems. There's a high addiction rate, and it's interesting because some people get addicted to benzodiazepines. Some people have a better ability to take them. But when people have episodic vertigo, they should have something to help them stop the vertigo. And I think, you know, lorazepam. I think you have all of them here in Deutschland. Just a low dose at the time of headache, maybe at most 2 Tage in the Woche, you know, not so often. NSAIDs sometimes work. Scopolamine patches, you know, what you take on Schiffen, right, for motion sickness, pretty good, but they have some side effects. Promethazine, neuroleptics, they can help. G-PANTs, maybe, and you'll hear more in a minute. And lasmiditan maybe can help acutely. These are some non-pharmacological things. It turns out that there are many exercises and things that do help vestibular migraine, including reducing stress, avoiding triggers if you can, less screen time. Auf Deutsch, screen time? Same, screen time. So it's Blaulicht is very disturbing for migraine, and I think also for vestibular migraine. Magnesium, riboflavin can help. Moderate exercise, not extreme exercise, not heavy exercise, but moderate exercise, biofeedback, psychotherapy, Tai Chi. I really like Tai Chi. And I think the reason Tai Chi helps is because it's a balance, training. I think we learn to augment our vestibular system, perhaps with dorsal column, perhaps with somatosensory learning. I think it really helps people. What about preventive prophylactic treatment of vestibular migraine? Flunarizine and lamotrigine have the best evidence. They really do seem to help, both of those. They have side effects, but you can use them. They really do help people. There's some other studies. I won't go through them because I don't want to take too much time, but there's some other studies that were suggestive, and these things can help. Caffeine, stopped caffeine or tryptamine, topiramate, propranolol, venlafaxine. vestibular rehabilitation, some other beta blockers, CGRP blockers were looked at. The initial data did not look so good. And the problem is, most of these studies for vestibular migraine, small numbers, not very many people, not controlled, and the definition of vestibular migraine kept changing from study to study. Even in the middle of one study, they would change the definition. They would say, oh, we don't have enough patients, let's change to probable vestibular migraine. So they're inconsistent. But at UCSF, we decided we would study galcanezumab for prophylaxis of vestibular migraine. This is our study. We ended up having 38 patients with vestibular migraine or probable vestibular migraine, and we used a scale that we created called the VM-PATHY scale, which looks at improvement or no improvement in vestibular migraine, and we had patients on galcanezumab for 3 months. And we had pretty good results. This is the difference between placebo and galcanezumab. It looked like it really did help some patients quite a bit, and the overall average was good, so we published that in Headache last year. This is the scale we invented called VM-PATHY, because there was no scale to measure progress in vestibular migraine. So we invented this scale and we validated it, and you can look it up, and you'll have it in the slides there. What about vestibular rehabilitation? Everybody with vestibular migraine at one time is told to go do vestibular rehabilitation. Is it a good idea? Maybe, but it also makes people sick, right? Because if you're already having dizziness and you do these maneuvers, it doesn't feel so good. This is one that's kind of funny. The barbecue method, have you heard about this? The barbecue method, they actually take the person and roll them. And there are some other things that can be done physically, and these are studied, but the data are not ready. And it turns out that some of these vestibular rehabilitation exercises are even better for PPPD, so we should think about that. So to summarize, I have a list here, things that might help. And you know how it is in migraine. You see a patient, here when you see patients, they've already tried many different things, right? So same thing here. We have a list, we go through the list, and we see what works. We usually give people a month, 1 month of a trial, and we go through the list. So let's look back at our cases and think about what they have. Case number 1, migraine, sometimes with vertigo. So I decided that case was basically migraine, not necessarily vestibular migraine. I think, migraine. And I would use migraine prophylactic treatment and acute migraine treatment. And this patient, this real patient, did not need any other kind of medication. And when he got an episode of headache with vertigo, triptan was perfect. It stopped everything. Number 2, history of migraine now has not so much headache, not very many headaches, but episodes of vertigo. I think that probably is vestibular migraine. So we call it this probable vestibular migraine. Maybe we're missing something. Maybe it's vestibular problems of some other, maybe it's benign positional paroxysmal vertigo. I don't know, but we use migraine prophylactic treatment plus acute vertigo treatment. I think this patient had alprazolam at the time of vertigo attack. It didn't happen very often. Person was not going to become addicted to alprazolam. It worked really nicely, but she keeps it in her purse. She has it. She has it ready. And finally, number 3, this man from Silicon Valley. Long episodes of vertigo, no headaches, testing normal. I don't think this is vestibular migraine. But these are the patients I get that are sent to me all the time. And I don't know what to do. I write in my note, ich denke, das ist nicht, es ist nicht vestibular migraine, but I try some treatment, I try medication, and I send them back. So, conclusions. A practical definition of vestibular migraine. Here's the best one I came up with. Spells of vertigo, some accompanied by migraine symptoms like headache. spells of vertigo, sometimes with something like migraine. That's my best definition. But we should we should work hard to make sure we're not missing some labyrinthine problem, medication effects, vascular problem, epilepsy, posterior fossa lesions like cerebellar lesions, stroke. We should work hard. For acute episodes of vertigo, triptan, maybe, benzodiazepine, maybe anticholinergic. And for prophylactic treatment, I think CGRP monoclonal antibodies is definitely something to think about. They can be expensive, so we don't always use them, but beta blocker, calcium channel blocker, I think those are good places to start. Lamotrigine, flunarizine, topiramate, maybe tricyclic antidepressants like amitriptyline. What are the research questions? We have to work on these things. We can't just take care of patients. We also have to ask ourselves questions, learn from our patients. I know you do that here. I know Dr. Gogol does a lot of work in this regard, and maybe we work together sometime. That'd be fun. These are the questions that I came up with. Is the diagnosis of vestibular migraine valid and reliable? Is this a good definition? Number 2, should we use probable vestibular migraine patients in research studies, in clinical studies? I don't know. I just don't know. I think no, because then it becomes not specific enough. Next question. Are there physiological or imaging markers of vestibular migraine? Well, this is what we want for everything. We want markers for migraine so that we understand it better. We want markers for tension type headache. We would like to have these. Maybe there is something. Maybe there's a test, electrophysiological test or imaging test, MRI, I don't know. Diffusion tensor imaging, something. Is there a signature for vestibular migraine? I would like to see that. What about the genetics of people with vestibular migraine? I think there are some families that I know who seem to have a lot of vertigo with their migraine attacks or just attacks of vestibular migraine. And what's the best treatment? We always want this. How should we treat our patients? And that is all I have to say. Thanks to my staff at UCSF. That's our headache center. Also, thanks to the staff of the Balance and Fall Center. They're in the Department of Otolaryngology. They have a dizziness center. And we work together. We work together on the CGRP project. And thank you so much for inviting me to the Schmerzklinik one more time. It's so nice to see you all. And I hope I can maybe answer some questions or arguments.
Thank you very much for guiding us into this very difficult area. And we have some similar topics, headache classification. 30 years ago it was so bad, and now we have some excellent classification. Vertigo, my experience, my feeling is we have the same situation as we had 50 years ago with headache. It's so huge field. We have peripheral, we have central vertigo symptoms, but in between there are so many other topics, and so it's difficult to understand it. If we don't work all the time on this field, it's really very difficult. So, but our patients have this once a day, episodic or chronic. So we need to work more on this field and to bring the things together. In Germany, we have, I think, in Munich, one center for
That's the one, yeah.
vertigo.
Yeah, it's the.
And also one in Lübeck.
Yes.
Oh, really? A little bit?
Yeah.
Small
But-
one consultant.
Yeah, but scientific evaluation of vertigo is very, very rare, even in our country. And so it's good if we work more and more on this. But I think we have more questions, please, colleagues.
I think the interesting thing about the Munich, the München Center, they're very smart and they have done a lot of work, but their definition is different than ours.
Mm-hmm.
So if you don't have the same definition, you see this pie chart. Using one definition, that many people have PPPD. Use a different definition, that many people have PPPD.
Yeah.
It's difficult.
So my first question would be, why it is called vestibular migraine? Because vestibulum is something peripheral. It's
I know.
outside. And I think migraine is a central syndrome, though it's generated in the brain, in the cortex, and now we call it vestibular migraine. And we wouldn't also say if someone is vomiting, stomach migraine.
Right.
Earlier they did, but now we would not accept that. So I think there's a lot of things to do.
I completely agree. It would be better to call it vertiginous migraine, I think. Yeah. Or have a new word. I mean, we have a lot of words in migraine classification that make no sense. Chronic migraine makes no sense.
Yeah.
Yeah, but I agree. Vestibular migraine, it would make sense if it were a peripheral problem, but it's not. It must be central.
I have learned with topography when I was in my training years, and so I learned if it is a peripheral syndrome, so you have a direction of the movement.
Yes.
Yeah, like merry-go-round or lift experience and so on. But if it's a central thing, you feel like you are standing on a boat and everything is moving. So this is, or you have too much alcohol inside, you will feel this undirected movement syndrome. And I consider that vestibular migraine, which we think is a central syndrome, and we have this undirected movement experience.
Yeah, the problem, I agree with you, the problem is that some people with migraine do truly experience movement. That's the problem.
Yeah.
So, again, it's a Venn diagram, and I don't quite understand it. But I think that's why I think this is a brainstem issue, not cortical. I think that the pathology is in balances in brainstem activities, vestibular system, nausea, vagal systems, and nociceptive systems. I think that's where the imbalance is, and that's where I think most migraine people fit. And then the question is, how different is vestibular migraine from migraine with visual aura? Maybe not so different. I think they're all similar, but I want to take the patients who don't have migraine and put them somewhere in a different category, because they will respond to different treatment. I find myself in the position many times, even though I think they don't have vestibular migraine, now I'm the doctor. I have to treat them. So I use other things, patches. Do you have these? Do you have these transdermal scopolamine patches? Yeah. Be careful. Be careful. They really work nicely, but if people keep using, they can become very toxic, dangerous. Yeah.
You mentioned this prevalence of, I think, 2.7% up to in one of the studies. In your experience in San Francisco, is vestibular migraine a rare diagnosis to make, or is it actually close to this 2% of your patients?
I don't know yet. This is a good question. I don't have the data to really answer, because I think what happens is...
I mean, from the patients you see in the clinic, do you make this diagnosis often, or is it really like an exception?
Yeah, I hear you. It's maybe like 3, 4, 5%.
Right. Okay.
And they most of those people have some persistence of the vertigo or the imbalance or something, and they're very uncomfortable most of the time. Those are the patients that I see. But I have a center, so I don't know about the rest of the rest of the medical center.
Yeah.
But they're very uncomfortable and disabled.
Mm-hmm.
They can't work. Their relationships are difficult. They're very uncomfortable. Yeah.
Thanks for the talk. One question.
Sure.
Vestibular is a very difficult symptom, especially to identify through to objective tells about it. And what about the pathology behind it? Is there an overlap between anxiety, between depression, and high prevalence of vertigo, or especially migraine with vertigo?
I don't know. I think that the question is, does anxiety and depression cause vertigo, and can also, can vertigo cause anxiety and depression? I think you're asking, what's the relationship? I think with vestibular migraine, I think it has got not a large factor. But with PPPD, those patients who don't have migraine features, depression and anxiety is very, very common. So why? Why is that? And we don't know. We don't know yet. I think that, I'm writing an article right now called Stress Causes My Headache. And I'm writing it because I don't know what stress is. I think I'm starting to know. But here's my definition of stress. I'm getting to your answer soon. Here's my definition of stress. A situation where the demands on us are greater than our capacity. Does that make sense? We're people asking us to do more than we can do. All right, if that's true, that starts to resemble physiological stress. And physiological stress in the brain has real markers, has real physiological consequences, and I think that change in brain chemistry could, lead to migraine. So I think there could be something to that. If emotional stress leads to physiological stress, which I think maybe does, then that would be a way for it to cause migraine. The interesting group, of course, is this PPPD. There's so many people with PPPD, and we don't know how to diagnose it very well, but many of them are anxious and depressed. And of course, if you have a lot of vertigo, you're going to be upset, you're going to be anxious. So that direction, for sure. The other direction in vestibular migraine, I just don't know yet. We think about it a lot because so many of our patients are depressed. I looked in the hallway as we walked in. It's easy to see, right? It's easy to see that there are a number of patients with headaches that are depressed, that are anxious, and it's easy to say, oh, they have their headaches because they are depressed. I think it's the other way. I think migraine is a physiological, genetic problem that leads to a very difficult life and leads to anxiety, leads to stress, leads to depression. But most doctors, they see their patients, they just have a quick look at their patients. They look like they have headaches and depression, and they put that together somehow. But we need to know more, just like you said, we need to understand this better to help our patients. Yeah?
Thank you very much. It was so interesting.
It's my pleasure.
And it shows how difficult the diagnosis is. If you treat a patient with triptan and it was an aura, what can happen? Is it dangerous for the patient?
No, I don't think so. I think triptans are safe in aura. What do you think?
I haven't heard everything, so.
Oh, she asked, is it safe for a person with aura to take a triptan right then at the time of aura?
Yeah, so this is a controversial question because we have the past, and in the beginning of the triptan treatment we wanted sure if there's a vasoconstriction and aura is caused by a vasoconstriction, so we said it's better not to use it, but if you have a very, very common aura, you have some flickering light and it's always the same, it takes 5 minutes or 10 minutes, and you use your triptan and it will work after 30 minutes when it have access to the blood, and nothing will happen. So I think we have to differentiate if we have a very, very common aura which is always the same and it lasts only 5 or 10 minutes, I have no problems to use it. But if you have a brainstem aura, for example, and you don't know, is it really an aura or is it a transitory TIA, can it produce a stroke or so? In this situation, I would not recommend you use it. So the answer is it depends what kind of aura it, what kind of symptom it is, and so we can say it's okay or it's not okay.
That's a better answer. I'll say it in English because I have my way. If you have excluded TIA and stroke, I think it's safe,
Yeah.
but you must exclude that.
Yeah. So aura is only an aura if it disappears. So if it's going on,
Yeah.
you don't know what
You
is
just don't
going
know.
on.
Yeah. If you know, then I think it is safe. But if you don't know, be cautious. Yeah, be cautious. Was it Sicherheit? Sicherheit. Yeah. Am I saying it right?
Yes,
Uh,
sicher.
What's a better word for caution?
Vorsicht.
Vorsicht.
Yeah. One quick question. Botox for vestibular migraine, you didn't mention that you wouldn't use it specifically for vestibular migraine, right?
For some patients I might. For patients who have a lot of headache attacks, I think I might. I don't think it would help people with just attacks of vertigo, or mostly attacks of vertigo. But I think there's real hope with CGRP, playing with CGRP a little bit. I think there's hope for people with vestibular migraine. I think, healthy lifestyle, exercise, Tai Chi, I think there's hope there too. It's not because it cures vestibular migraine, but it strengthens, it builds other protective systems, like posterior column, somatosensory, visual, and other balance systems that I think protect people from it. They give us new tools. So I like that concept. I'm trying to think. One of my patients was sure that occipital nerve blocks helped her vestibular migraine. And so she came to see me every month for occipital nerve blocks. And she said, "Oh, this is so great, I don't have my vestibular attacks." And then then came COVID, and she couldn't get occipital nerve blocks, and she was fine. So, maybe occipital nerve blocks not so important. Well, I hope this helps. I think you will be seeing many of these patients. The way I see them is my otolaryngological friends, my ear, nose, and throat friends, send me patients. That's the way I see these people. And I would say most of them do not have vestibular migraine, but I make some suggestions, but some do. And I think that's probably the way you might see these people. They're referred from ear, nose, and throat, or maybe you get to know them here in the hospital, and they say, "My headaches are better, but this vertigo, this dizziness is not feeling so good," and you have to then take care of that too. Well, thank you. Anything else? Any more?
Some more questions? No, thank you very much.
It's my pleasure. Thank you so much for listening.
You gave us a lot of new ideas, and you motivated us to stick more on this topic and to work more and to learn more. And so thank you very much.
It's my pleasure. Thanks for having me. It's really.
Ja. Vielen Dank, dass ihr alle da wart.
Vielen Dank.
Yeah.